We now move ahead with the next oration of this Congress, and that is the WCCPCI 2012 Dr. H.S. Wazir Memorial Oration. And this year, the topic is Pulmonary Hypertension Management Strategies 2012 and Beyond, to be conferred on Dr. Rakesh Gupta from Delhi. May I invite the chairpersons of this session. Please welcome Dr. A.K. Omar, Dr. H.K. Chopra, and Colonel S.K. Parashar to join the proceedings on the dais. And we'll have a total time of 18 minutes, 15 minutes for the delivery of oration and 3 minutes for the oration to be conferred on Dr. Gupta. May I request the chairpersons to kindly invite Dr. Gupta. Thank you.
Well, Professor Wazir, we have the privilege of knowing him very well because we were in the same city, and he was also he was the professor and head of the Department of Cardiology in the most prestigious All India Institute of Medical Sciences, New Delhi. He had a very special interest in all aspects of cardiology, but I think when we used to meet, he was more interested in hypertension or so. Excellent speaker. Whenever he used to give a talk, it was so clear that we never had to ask any questions or so. And besides that, I think he was, if I am not mistaken, his family year, he was also honored by the Government of India. Many times he was the, I think, the personal physician to the President of India also. That is a rare honor. And a very, sometimes when he's in a mood, a very jovial person. He used to give us a lot of anecdotes or so. So considering his versatility and his knowledge and his position, it was decided unanimously that we must have a oration in his name. And we are lucky to have his wife and his son sitting here, and we are privileged for that. And that oration we wanted to give to a person who is one of the, now who has emerged as one of the most leading figures in cardiology and echocardiography, and is well recognized in this country. That is Dr. Rakesh Gupta. Dr. Rakesh Gupta will deliver the oration. Thank you. I think it is 20 plus 5.
Good afternoon, friends. It's my privilege to deliver this particular talk in memory of our old brevet, Dr. H.S. Wazir sir. As Dr. Parashar sir said, he was the most jovial person. Look, what happens after a lunch? And that's too soon after a lunch. Everybody goes into diastole. And let me show you a couple of clips before getting on to my two presentation. What are the priorities of a life? Look, this city is fully flooded with water. This guy is busy with getting him shaved. 2, a very apt sentence of line which is often seen in Delhi autos. Never say me bhaiya if you are sitting with a girlfriend in an auto. 3, if this guy wants to get into army, howsoever small his chest may be. 4, English is a tricky language. Always use aptly. And this is what is seen in one of the signboards in UP. Ghatak I Physics classes for IIT, AIEEE, PMT 100% engineering. हम एक रिक्शा चालक को भी फिजिक्स सिखा देंगे. Aptly, a very good photograph for communal harmony in India. Excellent. Direct, nothing in between. Look, this was a signboard outside a hotel in a washrooms. This is meant for a male, gopi. And if you happen to be a female, it's gopika. Warning, outside a toilet booth. Due to industrial action, this toilet will be closed tomorrow. So do as much as you can today. That's what the government promotes as on today. Save petrol. I don't know how. This was exam pattern, 1995, also on questions. 2000, please answer any 5. 2010, answer A or B. 2015, at least read the question paper. And look at the time, it will be 2020. And if we happen to go with Mr. Sibbal's physiology or philosophy, this is going to happen in 2020. A, B, C, D, E, F. A boy can do anything for a girlfriend. If you put it reverse, girls forget everything done and catches a new boyfriend again. Some people says behind every successful man there is a woman. But nobody knows the fact the woman only chooses a successful man. Always have a patience to look at a total diagnosis. Here is the diagnosis. Look what exactly the diagnosis is. Have patience. You'll have a true diagnosis coming in a couple of seconds. And that's what we do a mistake all the times, you know. Here is a lady who was getting photographed. And this is what the lady it was. Everybody look at a Kingfisher Airlines. There's no more a Kingfisher Airlines anymore. And this guy, he says, I always take things personally. And you know, this is the way he used to take things personally. At one time, Malaya had lot of cash, that's piles of cash. The cash flew away, only the piles remains. And that is known as the Kingfisher Airlines. And that's all. And before I get on to my real topic, I hope you must be all awake by this time now. Well, that's what we're going to talk about, as I'm really thankful and I'm really honored to deliver this talk of a pulmonary artery hypertension. Management issue 2012 and its beyonds. Well, all of us knows it's a progressive disease leading to change in the pulmonary hemodynamics that eventually causes right ventricular enlargement and hypertrophy and leading to right ventricular failure. In today's consensus of 2009, any mean pressure more than 25 at rest or more than 30 after exercise is considered to be a pulmonary artery hypertension. And if you look at the causes of pulmonary hypertension, if you exclude pre-capillary versus post-capillary, if you have a left-sided involvement and the pulmonary capillary pressures are high, we call them as a left-sided illness giving rise to pulmonary hypertension versus another one. And this is a diagram from JACE 2010 talking about if pulmonary capillary pressures, they are normal, it's the right-sided pulmonary artery hypertension versus which is increased on the right side. Classification of pulmonary hypertension as on 2009 is based on the etiology. Group 1 talks of idiopathic, 2 talks of a left-sided heart disease, and what we are going to deal is a group 3, 5 and versus 1. I'm going to exclude 2 important issues, that's left-sided versus pulmonary embolism, pulmonary artery hypertension. And the most important thing is why classification. Classification is basically based on etiology. And based on etiology, the survival which is dependent. If it's a congenital heart disease versus postpartum versus pulmonary embolism versus HIV, the classification and leading to prognostic value of its classification. And that's what our data from our lab, we say almost 12% of people presenting into our echo lab, they have a pulmonary artery hypertension evaluation causes. What all you need to do for evaluation of efficacy of a therapy before I jump onto therapy? We look at a mean pH, we look for a pulmonary vascular resistance, we look at an RV function, right heart catheterization and 6-minute walk test. That helps you in evaluating the efficacy of pulmonary artery hypertension. Treatment is absolutely based on various issues, and the first and foremost which I talked about, its etiology, and second is the functional class. The functional class is based on acute vasoreactive therapy which helps in evaluating the functional class. As far as etiology is concerned, so many things which are concerned, as I said earlier, I'm going to deal not on a left-sided heart disease or a thromboembolic phenomena. I'm going to develop on 1, 3 and 5 etiological factors. Functional class. We look at the functional class based on acute vasoreactivity test. And this is an algorithm which talks about all this kind of a phenomena. If it's a vasoreactive test is positive, we always look at calcium channel blocker therapy. If it improves, it's fine, we continue with the calcium channel blocker therapy. If it does not, we switch over to functional class 2, 3 and 4. And this is what the survival based on the functional class as such. New York Heart Classification, functional class 1 and 2, we have a significantly good survival in comparison to 3 and 4. What are the various pharmacological methods or therapies which are available for therapy of pulmonary arterial hypertension? Apart from calcium channel blockers, we have a 3 set of drugs. One is a prostacyclin analogs, endothelium receptor antagonist, and the phosphodiesterase type 5 inhibitors. However, the treatment is not curative. It's a long-term therapy which is often acquired, and people, they often, in spite of having a therapy, they still have a downgrade progression of a disease. What are the various drugs which are used in pulmonary arterial hypertension? Calcium channel blocker, we all knows about it. Prostanoids, which consists of these 3 drugs, endothelium receptor antagonist, and phosphodiesterase type 5 inhibitors. Management, as I said a couple of minutes back, depends on the functional class as well as on an etiological classifications. What are the various trials which helps in evaluating? Random trials are relatively short terms of a duration. Long-term efficacy of the drug therapy is important to assess because the efficacy may become less as the disease progresses. This is one, again, the algorithm which talks of pH clinical evidences and drugs approved. Let me take one by one. Prostanoids, epiprostenol, treprostinil, and elaprost. One of these drugs is an IV preparation, second is a subcutaneous versus IV, and third is inhalation therapy. A comparison of constant IV prostacyclin with conventional therapy of primary pulmonary heart hypertension. In comparison to conventional therapy, a continuous IV infusion of epoprostenol produced symptomatic and hemodynamic improvement as well as improved survival in patients with severe pulmonary arterial hypertension. Problem, if we do not have a continuous infusion facility, we switch over to a subcutaneous treprostinil. It often gives you a greatest improvement in various other factors which we look at in management of these people. Oral Beraprost, first biologically stable and oral active prostacyclin analog. Mean dose is almost 80 micrograms 4 times a day, and it's very good and approved therapy as far as Japan is concerned. Another one is the inhaled elaprost, delivered by inhalers, relatively short duration of action, and go by inhale 6 to 12 times a day. Side effects includes cough. Symptoms are linked to systemic vasodilatations. Well, these 3 drugs, they found their names, but as far as the various things which are concerned, in their utilization in day-to-day practice was significantly limited in our country. Our country is exposed to these 2 drugs to a large extent. What is we call them as endothelial receptor antagonist. Bosentan and ambrisentan. There's 2 drugs which have been widely used for last 2 to 3 years in our country, where we use them in oral formulations. One is 1 to 2 times a day, another drug which is available for single time use per day in therapy. Many papers have been published on this bosentan, used for quite a long time, except for the fact it has got a significant interference with the hepatic enzymes. And if we happen to monitor the hepatic enzymes sustained and a constant fashion, a regular interval, people, they do benefit with this kind of a bosentan therapy to a large extent. And this is what a paper talking of a long-term effect of a bosentan in patients with pulmonary arterial hypertension. Treatment success with the monotherapy was maintained in 78% of the patients at the end of 5 years and almost 41% at the end of 5 years. Long-term success shows the significant low level of natriuretic pro-BNP along with 95% survival after 5 years of period. Another drug which has recently become available in India, that is the name of Endoblock, being marketed by one of the company, which has an ambrisentan, which is used in 5 to 10 milligram of doses. This is one trial which published in 2008, talking of a ACE study 1 and 2, which was a large trial talking of a double-blind, randomized, placebo-controlled, multicentric trial. And what does it said? That there's an improved exercise capacity in patient with pulmonary arterial hypertension. Improvement was observed for several secondary endpoints in each of the study, although statistically significance was more variable. It is very well tolerated and especially associated with low risk of aminotransferase abnormality, which was true with bosentan. It led to multiple variables in improvements like 6-minute walk test, significant improvement in time to clinical worsening, significant improvement in functional class, minimal hepatotoxicity, that was the most important point, and minimal drug-to-drug interaction. And on top of that, patient compliance with single dose was excellent with this particular drug. Two another drugs apart from bosentan and ambrisentan, which found a significant use in pulmonary arterial hypertension in day-to-day practice, is sildenafil and tadalafil. Obviously, everybody knows sildenafil has been initially used for some other factor like erectile dysfunction. Subsequently, its effect was found in pulmonary hypertension, and many people they uses the sildenafil or a tadalafil in this particular use in day-to-day practice. Many papers starting from NAGM 2005 talking about the sildenafil in day-to-day practice, of the utilization, improvement in exercise capabilities, improvement in 6 minutes walk test, and these are the all various studies which are elaborated talking of the use of sildenafil in day-to-day practice. But the problem comes when the patient keeps on deteriorating in spite of all those available drugs. The era which moved on from a single drug therapy to talk about sildenafil along with other prostanoids, whether it could be epoprostenol or iloprostenol or sildenafil with bosentan in combination therapy. And sildenafil improves pH, which is refractory to earlier drugs, but the things are significantly variable. This one Super 2 trials which talked of after 3 years, 183 people on sildenafil almost 80 milligrams 3 times a day showed a significant improvement. And it moves on to say that people who were using 3 times of a sildenafil every day, they were switched over to tadalafil in the SITAR study and showed a significant improvement, which was as good as the therapy with sildenafil. Well, in spite of all this, the disease progression keeps on happening. And the worst part of these people of pulmonary hypertension is to develop a RV failure. And that's where the endpoint starts for these particular people of pulmonary arterial hypertension. Sometimes we are left with no therapy, no choice, in spite of all possible medical therapy. And this is what all we can do is, we do not do significant improvement by doing either an atrial septostomy, or we can switch over these patients possibly for a lung transplantation. And certainly thromboembolectomy is when we have something to do with the embolism or a right-sided failures. This is what the optimal therapeutic strategy as on today, that's 2012. If we have a pulmonary arterial hypertension where the cause is from type 1, type 3 or 5, we look to anticoagulate them, give them a diuretics and oxygen therapy along with the digoxin. Subject them for a positive acute vasoreactive test. If it's positive, we put them on oral calcium channel blocker. It showed a sustained improvement, we continue with the calcium channel blockers. If it's no, the vasoreactive test is negative, obviously we have a choice of all this. We class them as low risk people or a high risk people based on this RV failure involvement, progression of symptoms, WHO class, 6 minutes walk test, whether there is evidence of pulmonary embolism or not, echocardiography, hemodynamics, and BNP levels. And if they are low risk people, we either give them ERAs, endoseptal receptor antagonist, or phosphodiesterase E5 inhibitors orally. That's our first choice in majority of our cases as on today. And If the disease still progresses, we consider a combination therapy. And if the still things do not improve, even with a combination therapy, and that's what it happens majority of time because it's an ongoing illness. When RV function deterioration happens significantly, we look for either atrial septostomy only to buy time for possibly a lung transplantation. Future, beyond 2012, possibly we'll be talking of vasoactive intestinal peptides, glucagon, growth hormone releasing factors, inhibit platelet inhibitions and proliferation of vascular smooth muscle cells, looking at drugs in inhalation forms, selective serotonin reuptake inhibitors, fluoxetine, which is still in experimental form and yet to be tested with patients with PAH, and most probably thing is we are looking for a double-blind random controlled trial for multiple drug therapy in cases of pulmonary artery hypertension. Thank you very much for your patience here.
Thank you, Dr. Rakesh. We all agree that this is the pulmonary arterial hypertension is particularly one of the very serious disease, and it has got diagnostic dilemma as well as the treatment dilemma, and still the outcome is very dismal. It's very nicely Dr. Rakesh has summarized the whole spectrum in just 15 minutes, and I think he definitely has done a very good job.
Thank you, Dr. Omar. I think it is a very prestigious session. First, for the reason that it is in the oration in the name of Professor H.S. Wazir. Professor H.S. Wazir, for the people who do not know him from abroad, was a very famous cardiologist. And whatever I am doing in CSI is all his stimulus. He was the secretary of CSI Delhi branch, and he was the one who inspired me to become the secretary of CSI. And I think I am really privileged by listening to him, and this oration has been kept in his memory. He passed away. I am very fortunate today that his whole family is here. His son, who is an endocrinologist in Medanta Medcity, working with Dr. Naresh Trihan, and Mrs. Wazir is also here, and Mrs. Trihan, and the children are all here. And this oration is bestowed upon none other than our own Rakesh Gupta, who is the key person for the conference, whatever we are doing here. It is his hard work. And the way Rakesh has presented the data is a mind-boggling. He has given absolutely mind-boggling approach to a patient of pulmonary hypertension, whether it's primary or secondary, by pharmacological, non-pharmacological, mechanical and surgical interventions. And the various algorithms which is shown, I'm sure you might have gone through it. I think it was a very outstanding presentation. Let's give a big hand to Rakesh for his outstanding presentation, and I request Dr. Wazir's family to please come on the dais and bestow upon this important narration. I request Dr. Omar to please join me to do this job.
Ladies and gentlemen, the WCCPCI 2012 Dr. H.S. Wazir Memorial Oration has been conferred on Rakesh Gupta. Many congratulations, Dr. Gupta.